My name's Gus Gazzard from Moorfields Eye Hospital, Director of the Glaucoma Service there, and also at UCL University College London, Institute of Ophthalmology here in London. We've got some excellent speakers lined up for you this evening. Faisal Ahmed from the Western Eye Hospital here in London, Professor David Crabb from the Crabb Lab at City University in London, myself briefly, and Francesco Odone from the Eye Hospital in Rome, speaking to us from Italy. So I'm looking forward to our discussions. We will try to keep our content brief enough that we have some time to answer your questions where possible. There's quite a lot to get through because there's some really excellent material in the talks that I've just previewed. Really looking forward to a very informative evening. So without more ado, we will move on to our first speaker, Faisal Ahmed, and he's introducing us to the ideas of disaster mitigation, particularly what we can try and do in the climate of COVID to save as much sight as possible with the limitations the current environment is putting on us. Thank you very much. Over to you, Faisal.
Thanks very much, Gus. So I'm going to talk about disaster response with regards to COVID-19 and try and use a bit of my non-ophthalmology experience working in a humanitarian charity with disasters. So the UN defined a disaster as a serious disruption or functioning of community society involving widespread losses and impacts which exceed the ability of the community to cope. On the right-hand side, you have a picture of the Boxing Day tsunami that happened in 2004, with pictures before and after the tsunami hit the Indonesian islands. So we have to move on quite quickly. We only have 12 minutes for this, but essentially disasters are categorized into levels 1, 2, and 3, where level 1 disasters are dealt with locally with people on the ground. Level 2 require regional help, and level 3 are the large-scale disasters such as tsunami disaster where external assistance was required. So in disasters in their characteristics are very, very different. One earthquake disaster is not the same as another one. On the top left-hand side, again, this picture of Indonesia. Next to it is the Pakistan earthquake where 80,000 people unfortunately lost their lives. Far right-hand side is Sierra Leone, where we were helping to manage people in Sierra Leone during the Ebola crisis. And so you can see with all these different disasters, there are different ways of responding. And you can see on the top right-hand corner again, the medical team wearing their PPE kit, which I'm sure there are some units still in England who require PPE. On the bottom right-hand side, there is our team working in close proximity without PPE in the earthquake environment, which happened in Pakistan. So as you see, they're all slightly different, and the response and the teams are all slightly different as well. So when responding to a disaster, it's very important that you have clear objectives about what your medical team is going to do. No different really to what you do in your own hospital, but making clear objectives is how you're going to achieve it. So it's important that we treat our patients in a timely manner. And this is a clinical timely manner rather than, for instance, in the UK, where we run on referred treatment time, and we have to stick within the times the general practitioners give us and national guidelines are for when we sent a patient and by which time we have to treat them. So during the disaster time, that goes completely out the window. It's completely done on not RTT, but NTT, need to treat. And of course, within disaster, we have to maintain good patient relationship, maintain team safety, which is done for us. We take that for granted in our normal day-to-day lives within the hospital, but we're more aware of that when a disaster setting. Treatments are modified when you're in a disaster to try and see if we can make them more efficient and quicker and have people operated on less. Of course, we have to maintain a very high level of professionalism at all times. And unfortunately, when you're in a disaster, you do have to prepare for losses. And again, that's something that is not necessarily something people think of all the time. I put this slide up purely to show you that on the bottom right-hand side, there are firefighters fighting the fire, but unfortunately, they're about to be injured with that wall on the left-hand side falling on top of them. So that's something that really needs to be looked into when we're dealing with disaster response. And there are phases of disaster response with regards to preparation, response, and recovery. So the preparation phase is where you do the planning. You plan to respond to a disaster before it happens. It's a critical stage of disaster response. You look at what events may happen, what sort of injuries are going to happen. This is where you put in your data of the type of injuries, where the incident's going to happen, access to your incident, availability of resources, and so on. You can then model the equipment required. For instance, in this COVID time, we should have known how much PPE was required. And we also look into training, so you can train through the scenarios with the new equipment that you may not be familiar with. And in a disaster environment, this is taking medical teams who are used to dealing with patients all the time, but training them up to be able to be independent in an austere environment, used to slightly different equipment, but trying to still have that professionalism and treat patients in the best way they can. And my job within my charity Humanity First was to make sure that people were as prepared as they were. You then go on to the response phase, where again, data, information about what's happening is important. The real-time information is important, so you can then respond accordingly with the adequate resources required. And then you move on to the actual patient treatment by the clinical team. Triage is important because, again, needing to treat patients at the right time is key to how we solve the situation of a disaster response, treatment and referral pathways. And then, of course, you have the recovery, preparation, debrief, and you go back to modifying your planning again. So what were the key lessons? Again, we've only got short lessons. So the key lessons were, one, we had to put our own course together so that we can train clinicians as to how to respond in an austere environment and not be part of the problem, but be part of the solution. So they had to be completely independent. And we set a course up, and eventually the UK government allowed us to run their first course for them about 2013. And it's fun trying to tell off orthopedic surgeons how to do their job while screaming at them, trying to distract them. And you know, we have moulages and actors playing injured and so on. So that's all good. The key lessons, I guess, from my experience of disaster response, I put in a mnemonic, which I just made up a few hours ago. Docs, so data. You need the information to be able to respond. You need to have good organization and communication skills within your disaster team, as well as communication with all the agents who are working in that disaster. And there has to be a coordinating system for that as well. That your team has to be safe, because if they're not safe, again, you're part of the disaster. And you have to, again, show compassion. There's no point being in disaster and saying, well, I'm going to lose all my bed mannerisms and treat people like robots. That's just not acceptable. So coming to the COVID-19 issue, so WHO defined COVID-19 as a pandemic on the 11th of March 2020. At that stage, there were there were 118,000 cases, over 4,000 deaths in over 100 countries. At the end of April, we'd already had 3 million cases and over 200,000 deaths. And of course, we all know with our daily updates that are happening that the UK is not doing very well, but overall, the numbers are still going up, and there are secondary waves of infection as well. So what did we do at the Western Eye? I'll give you a brief sign-up to what happened at the Western Eye. So middle of March, we were suddenly told that we're not going to have face-to-face appointments, that we're going to be doing mostly phone calls, and the only face-to-face we would see are the very, very high-risk emergency patients. For instance, today I had 11 face-to-face appointments with patients. And you see the numbers are roughly about the same of face-to-face and phone calls. In fact, there are more phone calls. With regards to patient communication, we kept that up with all the telecommunication we had. But of course, we're leaving ourselves with the deal of looking and fitting in these extra 1,000 patients per month that are happening just in the glaucoma service. With regards to surgery, we tried to look at an emergency surgical plan, which took into account the fact that we were going to lose our anaesthetists and lose theatres very quickly. So we quickly pooled and triaged all our surgical patients to make sure the ones who were time dependent and going to lose their sight very quickly were operated on soon. So we pooled the patients We had to weigh up whether we could operate them versus their risk of COVID-19 and push some patients back on oral acetazolamide. We also looked at the surgical procedures we performed and the management pathways that we had. For instance, in chronic angle closures, we were offering patients phaco surgery rather than a PI. But in this case, we just did PIs on anyone who was acute coming in, and temporize them and try and reduce the impact of doing surgery that involved aerosolizing procedures. Also reducing and in fact stopping all our GAs pretty much and going on to local with sedations at most, and changing the type of tubes perhaps we were doing. And also looking at MDLT, which is micropulse, as I keep getting corrected, micropulse cyclophotocoagulation, not MDLT. And we did publish a paper on that in the last 6 months, showing our early results on that, which are very promising on the recalcitrant glaucomas. So anyway, so we have this situation now where even within the Western Eye Hospital, we are pushing back seeing 1,000 patients a month in the glaucoma service alone. So we have this on the left-hand side, huge tsunami, secondary tsunami, which we are suffering in the hospitals and services that do chronic disease where we haven't been able to see our patients. And somehow we have to turn that tsunami of thousands of patients that need to be seen into smaller waves that are manageable. Otherwise, of course, that big tsunami is going to wipe us out. So again, we're in the same disaster situation where we have to keep clear aims and making sure that we're treating patients according to the clinical risk and not the RTT time required by government. And that, of course, the team is maintained with their safety and that we can maximize the work we can do. So there are various triaging systems that have been brought up. The Royal College of Ophthalmology in the UK have put one up. AAO, the American Academy, have also put triaging systems where they've defined which patients need to be treated and seen and operated on sooner than others. So there tends to be a RAG rating. What we say RAG rating is red, amber, green, and there are various modifications of this. Of course, there's a famous song, All We Need Is Love, but I would add, and data. So in disaster response, as I said before, data is really key to how you respond, because you need to know what your problem is in order to give an answer. And that's an issue we've always known since we were children. And so I'm just going to load up the Excel spreadsheet that Medisoft have very kindly made up this week, literally. And I have to thank Melanie Dodds of Heidelberg, who's put this spreadsheet together for me. So what we've done is we've been using Medisoft for over 10 years now. And what we have here in front of us is a spreadsheet of all the patients who have diabetic macular edema. And within that information, what we can do is look at the patients, say, okay, well, which patients have lost over 2 lines of vision since their last visit? So I can rub that out, press 1, and that will tell me all the patients who've lost over 2 ETDRS lines. I can look at all on the right-hand column here, patients who we've roughly categorized into they meet driving requirements in the UK, they don't meet driving requirements, they can be registered as partially sighted or they can be registered as fully severe sight impaired. And if I go along my spreadsheet, we can look at the times they were last seen and when their next planned visits are, as well as look at the diagnosis. All of this information will then be collated so that it will help drive us as to what's happening in our services. And if I briefly, as quickly as I can, show you, we've done the same. I had a quick look at, for instance, fast progressors in glaucoma with David Crabb's visual field audit tool. And we've modified it. So we've added in vision loss as well. So those patients who've not only have a high rate of mean deviation loss in their visual fields, but also those who lost vision on their acuity. And if we go on to the right-hand side, we've got the diagnosis, the number of glaucoma medications they're on. And all of this data will help us drive and be a smarter way of risk categorizing patients, not by purely their diagnosis, but also actually their functional vision, i.e. their functional visual acuity and their functional visual fields. So let's just go back to the talk. So that means we can risk categorize a bit smarter now. We can put in the factors of functional rate loss, whether they've got high IOP at the last visit, and how much medication they're on. We could risk categorize out, for instance, our glaucoma patients. It will help model our new service in regards to what the surgical list will be like and what our clinic list will be like over time. However, we have to take into account the fact that we don't necessarily have the data, and these spreadsheets will also tell us the data we don't know on our patients. So docs, as I said before, data, organization, communication, compassion, safety, key to the way we respond in this COVID-19 disaster. So at the Western, I'm just going to quickly put this through. So at the Western, we'll be looking at remodeling our service with regards to using the data that we now have. And I've got a service meeting tomorrow, so hopefully my leads are all looking in at what we'll talk about tomorrow. The spreadsheets allow us to risk categorize our patients not only into whether they go into consultant-led clinics because they're high risk, or into the monitoring service, which is for the low risk, or whether they go into the community or are seen by opticians in the community. In addition, the diagnosis we have, we can then see which patients need to be seen in a multidisciplinary team, and we can remodel the whole service. And on the right-hand side, well, we're never going to have 82 patients in clinic again, thank God, because we have social distancing. So we have to stick to that social distancing, so we'll never have that overbooked clinic. And this remodeling will also allow us to look at new ways of investigating patients, which may be safer than current models at the moment. So from tears come lessons. So the main driving point here is that we have to go on clinical outcome and not RTT and other measures that are not really useful in this particular time. That unlike other disasters where we're only trying to restore services, we can actually try and use this opportunity to improve our service, reconfigure them and make them safer, make sure the patients aren't in multiple clinics within our hospital, but in a joint multidisciplinary clinic. And of course, I'm going to be wearing this mask stuff for a long time yet. Thanks very much, everyone, and be safe. Just to say that, without friends and colleagues working with you, disaster response is awful.
Thanks very much indeed, Faisal. That was a great overview of a view from disaster relief and a view from the Western. We'll now be moving on to Professor David Crabb, who I'm sure needs no introduction to most of you. However, he is the professor in the Statistics and Vision Research Lab, the Crabb Lab at City University, responsible for some of the most memorable tools and most memorable graphics that have come out of glaucoma and certainly psychophysics research from the last decade. And I'm looking forward to hearing about how we can do our visual fields from our armchairs in the era of COVID, when we have social distancing, perhaps the ultimate social distancing in our armchair at home with a glass of wine. Thank you, David.
Thanks so much, Gus. That's a really nice introduction. And also, I'd like to thank Heidelberg as well for inviting me to make this contribution, indeed from my armchair, as it turns out. So I'm just skip this first slide here because in the interest of time, I'm talking about the burden of glaucoma. And obviously, from my non-clinical point of view, the real burden of glaucoma lies first and foremost with the patient and the patient families. But this evening, I really want to talk about the burden that's associated with the health service that has to look after the patients. And it was about 10 years ago that we did this back of a cigarette calculation to say that there's over 1 million hospital visits for glaucoma every year. And we know this is an age-related condition. We know about the fact that the demographics are changing, and therefore this isn't going to be a problem that goes away. We're just going to have more and more patients. And I guess in these current times, COVID or post-COVID, we know that this issue is going to become even more extreme and come under the microscope further. So what do we do with all of these patients? Well, there's an obsession in the glaucoma clinic with intraocular pressure. And I call it an obsession because we did a study on this a few years ago where we looked at 11 different clinics in England and Wales. And in that study, we showed that any kind of decision about intensifying treatment or increasing the number of times a patient would come into a clinic was always driven by intraocular pressure. Of course, it's a healthy obsession because intraocular pressure is the only modifiable risk factor for the disease. But and although we're getting much better at maybe quickly looking at the optic nerve in terms of OCT, it was apparent in that study that decisions were always or typically made based on intraocular pressure. The main point I guess I want to make this evening is that what I think is that the most important measure that we should be taking when we're monitoring patients with glaucoma is using automated perimetry. After all, the visual field is the measure that tells us something about the patient's function. It tells us about how glaucoma is affecting their sight. So my main point this evening is to say that automated perimetry is a critical component of following patients with glaucoma. Then again, anyone who knows me would turn around to me and say, well, you would say that because that's my research interest. And I'm not like a normal person, like all of you listening here. I'm someone who's interested in perimetry from a research point of view. In fact, I belong to something called the International Perimetry Society, where every 2 years we get together, and believe it or not, over 2 or 3 days, all we do is talk about perimetry. But like any academic meeting, it often ends up like a big party, really. But anyway, it's not just me who thinks perimetry is important, because again, this is a bit more evidence. This was a study that we did a few years ago where we asked specialists and subspecialists in glaucoma to sort of rank the importance of the measurements that they take in the clinic. And they all agreed about the importance of measuring visual function using perimetry, but at the same time said how difficult it was. The other part of this slide sort of makes the point that if we're going to develop a clinical trial for looking at treatments of glaucoma, then we have to consider visual function as the main outcome measure as well. So perimetry is definitely important, but what about the real experts? What do the real experts think? Now, the real experts are the people who've been pressing the button all these years, really. That is your patients that do perimetry. And this was a nice study that was done by Fiona Glenn in 2014, where she basically interviewed and had a focus group with a series of patients looking at what they felt was important in terms of their glaucoma monitoring. And you won't be surprised to know that they found visual field and perimetry the most challenging aspect of their monitoring. Many of these patients talked about the good experience that they had with perimetry, and often it was associated with good supervision and being in the right kind of environment. But something that I took from this study, which I thought was particularly interesting, is how few patients actually saw their visual field charts. So we're asking patients to do something called a visual field examination, and yet it seems many patients never really see the results of that examination. So can we do something better with perimetry? And I kind of regret putting a big red cross on the Humphrey perimeter there, because I don't think we should kind of move away from this standard that we have had in our clinic for 25 or 30 years. But we need to start thinking about ways in which we can supplement it or augment it. There are portable tests that are available for assessing the visual field, and there are other ways in which we might be able to measure the visual field without asking a patient to press a button, for example, so eye movement perimetry. So in the last couple of years, we've tried to combine these two things, and this rejoices under the name of eye catcher. And the idea here is we are developing a portable perimeter that can be run on a tablet-based machine using an eye tracker, the type of eye tracker that's used in gaming technology, so a very inexpensive eye tracker. And without going into too much detail about how this works, essentially there's no button. The patient just moves their eye to try and find this fixed intensity stimulus, and then we use the eye tracker to work out the starting point of the gaze to the end point when the stimulus is seen or not seen. And so the stimulus remains consistent, so it's like a fast so-called supra-threshold test of the visual field. And we've done some nice work on this. This was primarily done by Nicholas Smith and then followed up by Pete Jones. And we published a paper in TVST, I think it was about 18 months ago, and we showed that there was very good concordance between this very fast, rapid test of the visual field compared with the kind of reference standard, which is the Humphrey visual field. But if you look at the literature, you can find lots of papers like this where people have come up with their own kind of new visual field test. The important thing is, how does this actually work in the real world? So our next step was actually to take this into the real world. And the idea was to actually test people while they're actually in the waiting room of the glaucoma clinics. So what we did is we actually tested people using this new tablet-based portable perimeter in the waiting room. And the real world, you may not know, but the real world is actually Guildford. It's Guildford. And the head of the real world is Dan Linfield. So I'd just like to credit Dan Linfield because he was our collaborator on this study. And basically what we did is we measured about, 78 people in the glaucoma clinic, consecutive patients, random cross-section, and got them to do this test literally in the waiting room. And I'll just share some of the results. So here's a patient here with a relatively early visual field defect, a nasal step. And these are the eye catcher results. The red areas represent where the defect is. This graph shows that we're only measuring a certain part of the visual field. So we're only measuring the sort of central 15 degrees. And on a second run of the test, it was repeatable as well. Here's another example here. I hope the builds are working okay. This is a patient with a more advanced visual field loss. And again, the portable test picked it up quite nicely. Here's a patient who's lost all their vision in their inferior visual field. And again, we've managed to capture that with eye catcher. This is an interesting example because this is a typical patient. Well, they're not a patient. This is a false referral. So this is someone who's come into the clinic that's been falsely referred. Their vision is probably better than mine. And what eye catcher shows is that they also have a normal visual field. So this was very promising. And this graph, I'm not going to go into details. This is a very complicated graph, but essentially what we showed is by using this fast portable test, we could actually detect visual field loss at a level of -6 decibels MD with reasonably good sensitivity and specificity. And this is a complicated graph, but I want you to focus on that big green area over there. If you look in that big green space, you'll see that there are no patients. So what did this mean? This meant that if they passed the eye catcher test, it meant that they didn't have any visual field loss. So this is really kind of quite useful because this sort of points to the idea that you could give these tablet-based portable tests to people in the waiting room, and you could get an idea about whether they had visual field loss or not, or whether they needed further examination using the Humphrey. So what I'm clumsily getting at really is that this would be a very useful sort of triage tool. And also when we asked patients about, how they felt doing the test, that, they were a lot happier and found the test easier to perform and, and found it quite an enjoyable kind of easy test to do. The downside, the caveat is that it didn't work in 8 eyes, which doesn't sound that many, but that's around about 10% of our small sample. But again, I guess in a triage situation, if the test didn't really work, and the reason it doesn't work is because sometimes the actual eye tracker doesn't actually work. It's a very cheap eye tracker. So in a way, this would be, again, a way of sort of triaging patients as they sit in the clinic. I just want to get on to the sort of the main part of this talk, or the main final part, and that is, can we start to take some of this technology perhaps into patients' homes? And this is a study that we've been doing for about the last 18 months. It was funded by the International Glaucoma Association. And I should point out 2 critical people here, Pete Campbell and Tamsin Callahan. And this is my colleague, Dave Edgar and Pete Jones. So that's the team that's been working on this project. And I would say that what we're doing here is we're taking almost a Del Boy approach to perimetry. And what I mean by that is we're trying to fake the Humphrey in this kind of test. So the test that we have now no longer has an eye tracker. We're back to using a button, and we're actually trying to mimic or fake a Humphrey test, a full threshold test. So we're trying to get measurements at every single point. And the portable device that we use, or the tablet device that we can use, is a particularly inexpensive device. So if you went to Argos this evening, you could go and buy one of these for £300. And this is what the test looked like. So this is the Humphrey down here, and these are the eye catcher results. And you can see that we're doing our very best to fake exactly what the Humphrey looks like. But it's not all kind of Del Boy. There's some Star Wars as well. So Pete Jones, we're just about to publish this paper in TVST, and this is where he's been using the webcam, not the eye tracker, but the actual ordinary webcam that's built into your laptop to actually monitor the compliance or adherence of a patient as they're doing this particular test. And the study is quite interesting. We got 20 people, 20 volunteers. They started by coming into the university where we did an assessment on them. So they did 2 visual fields at the start of the study and then 2 visual fields at the end. We gave them the eye catcher device, and they did the eye catcher test once a month for 6 months. And I guess what's going to be the most useful output from this study is going to be the structured interview that we do with these patients. because when we talk about trying to do home monitoring, it's not just the technology that we use, but we need to kind of interrogate the human factors as well. And this is the big achievement, I think, from this particular study, is that we gave 20 of these devices to 20 people, and they took them home and they did the study, and we actually got 20 back, and nothing broke and nothing didn't work. And I'm just going to share some of the data because we're quite excited about this. This is for 4 patients. This is their Humphrey at the start and their Humphrey at the end. And these are the eye catcher HFA fields in between. And here they are for some other patients. And if you look at these, you can see that there's a reasonably good concordance. We also show that the MD values that we take from the eye catcher device are also highly associated or agree very carefully with the Humphrey values. And I just want to spend a little tiny bit more time on this graph, because this graph here represents the amount of variability that there might be between doing 2 Humphrey tests. So we're 6 months apart. So this would be the kind of level of variability that we would see in a clinical situation if we were in the position of just doing a Humphrey once every 6 months. Perhaps if we were doing a clinical trial, we would do more Humphrey tests. So this is a situation where you do 2 Humphrey tests at baseline and 2 Humphrey tests at follow-up. And you can see that the variability has been minimized. But what we're quite excited about is this is the level of variability that one would get purely because you're actually testing people more frequently. So we think that there could be particular advantages in using this device that patients could take at home to augment the perimetry that they're doing in the clinic. And these are not our patients, but perhaps it gives us flavour of what could be possible if our patients could do these tests at home, and also points to some of the comedy that we might see when we start looking at the webcam results. Now, I'm very aware that I've overrun time there, so I'll leave my thanks to the screen here and point out if anybody's interested in sort of following any of our research, then you can find us on the web and on Twitter as well. And just finally to thank everybody for listening tonight. Thank you very much.
Thank you very much, David. That was, as expected, a tour de force tour of what may well be coming to us and our armchairs in the next year or two. Well, hopefully in the next few months, if we're lucky. Certainly, we don't yet know what the current future for traditional visual field testing is in the COVID environment. A few questions coming in about that, but generally speaking, we don't know. So thank you very much, David. I'm sure there'll be a lot of questions later around the 2 different models of testing that you were describing, the button and the eye catcher tracker. I'd like now to move on, and I'd like to talk about glaucoma treatment. Paradigms is a grand word, but glaucoma treatment in the post-light era. And essentially what I'm going to do is briefly introduce some thoughts to talk briefly about a couple of ideas around what may influence our decisions these days around glaucoma treatments, briefly describe the light trial, and then probably wrap it up there because we've got shorter time and I'd like to make sure that we've got some time for questions. So funding acknowledgements, as always, I'm partially funded and largely funded by the NIHR Health Technology Assessment Grant, but also other funding bodies, including, not restricted to Fight for Sight, the IGA, College Ophthalmology, British Council for Prevention of Blindness, and thanks to all of those. And I'd like to kick off with actually is a David Crabb paper that reminds us about how long our patients are going to live, their residual life expectancy after their diagnosis of glaucoma. And this might be a bit of a sobering thought that some of our patients may go on to live as long as 30 or 40 years, given their rate of visual field loss. But the median for these patients is around 16 years. So for most of our patients, we're looking for 16 to 20 years of pressure control, and for a smaller number, slightly longer than that, years of pressure control to try and prevent their visual field loss. And within the group of retrospectively examined visual fields of these patients, there were very large numbers with very small rates of change in mean deviation year by year. And what I think this means we need to do is really what I take away from this is that we really need to focus our attentions on those patients who are down here at the left-hand tail with very rapid rates of visual field loss, and make sure that we're focusing our attentions on those, but not inflicting too much pain, suffering, or excess treatment. I mean, in that I would include too many excess visits on the bulk that are here in the middle, who, with adequate pressure control, change very little. So it really is a lesson that I've said in a post-light trial paradigm era, but actually it's also in a post-COVID era. The idea of less is more, and the least possible intervention and the fewest possible numbers of attendances at hospital will become critically important for these patients, given that there is a small but real risk of life-threatening infection in our elderly at-risk age group patients, or we expect at least several years to come. So on that note, we need to think about rates of visual field loss leading to disability. What can we aim to do to stop the very rapid, very fast progressors of -2 decibels a year here, to convert them to a slow but functionally and quality of life insignificant rate of deterioration in this green line here. If we're not careful, the immediate complications such as hemorrhage from surgery can rapidly blind a patient. Late complications such as blebitis from trabeculectomy can rapidly blind a patient. And we need to factor in all of these different rates of potential vision loss in our risk assessment and risk ratio balance. Now, the risk to be considered, the chance of event given the harm from event, something that's extremely rare but extremely harmful, is likely to alter our practice as much as something that's very mild but very frequent, and possibly more so. The rate of foreign body sensation after a trabeculectomy is very common, and we often discount it, although it does have an impact on quality of life. Whereas endophthalmitis is potentially very blinding, but after trabeculectomy at least extremely rare. And there's a risk-benefit assessment for both of these that changes over time, that changes over the duration of potential exposure, and that changes over the duration of the patient's life. And we have to remember that randomized controlled trials, even the longer trials of 3 or 6 year follow-up, are in the context of the patient's expected remaining lifetime from diagnosis, short-term, and also less good for detecting rare or late events. Infrequent events don't pop up very often in randomized controlled trials, and you certainly don't have enough data to be able to predict their frequency or predict their risk factors. And what we really need to do is be determining the number of needed to harm in very large patient populations. And that's hopefully where some of the real world data that we heard Faisal talking about gathering in Medisoft, and hopefully we'll touch upon with Francesco's talk later, will come into play, because the real world data in very large numbers may be able to give us some of that information that's missing even from well-conducted randomized controlled trials. And lastly, even when we have the data, the benefits, harms, and likelihoods of these are very differently perceived by different doctors. There's a confirmation bias around what we already expect. There are our own personal experiences of benefits, harms, and probabilities, and we've seen that most recently in individuals' experience of COVID having a very profound impact on doctors' appreciation of risk across the UK in the discussions that we've had around opening up our services again. Those in very less affected areas are somewhat less concerned about infection risk than those who have been in hospitals with sadly very high death rates. So where does that take us in terms of the LIGHT trial? Well, hospital statistics even before the LIGHT trial was published in 2019 showed there were the rapidly increasing attendances for laser trabeculoplasty. So a lot more people having laser trabeculoplasty across the country. Clearly, there's a changing environment there. And a shift away from the standard medication, preserved medication use across the country. We also have greater information now from randomized controlled trials showing that IOP reduction with a number of non-invasive, minimally invasive glaucoma surgeries are better able to control intraocular pressure, giving us additional pressure lowering above and beyond cataract surgery alone. So a lot of patients who were previously on treatment undergoing cataract surgery are now, in some randomized trials and some series, able to become drop-free. As in as many as 75 to 80% of cases in some of the Hydra studies of mild to moderate disease, predominantly treated with 1 or 2 medications preoperatively. So that's a very exciting shift in the world that we're entering. And some of the evidence for shifting towards a low drop frequency or drop-free world and treatment came from the SLT trial that we conducted, based in Moorfields, but at 6 sites across the country. And we had 718 patients, pretty much open eligibility for anyone with primary open-angle glaucoma or ocular hypertension, except for very severe disease. And we had 718 patients, and we treated them to a particular target with SLT with a standard protocol, 360 degrees. These were previously undiagnosed, no past medical treatment for glaucoma, and no other ophthalmic eye disease under review. And we escalated the treatment. So in one arm on the left there, they had laser first and then went on to medical therapies. On the right, they went straight into medical therapy. That's drops, as in the sort of standard treatment paradigm of the last few decades. We screened a large number of patients to get the 718, so we made jolly sure that we hung on to them. We had 91% at the end of the 3 years. Around about 3/4 of those had glaucoma, of which 2/3 were mild. We looked at quality of life outcomes, and they were very comparable between the two groups, as you might expect, because the majority of the medical treatment group were adequately controlled to a predefined target pressure, with only around 2/3 on only one medication. The baseline characteristics of the two groups were very comparable. And the clinical outcomes are also very comparable in terms of pressure control and mean deviation, because the pressure control was, we were treating increasingly intensively to a particular target. So you'd expect them to come out comparably. The number of visits at target were comparable. The gross visual field disc deterioration, however, was slightly worse in the drops first group, even though we're aiming to treat to the same target, and there were more cataract extractions in that group. But what was very striking were the greater number of trabeculectomies in those who were treated with drops first, and the greater number of treatment escalations that were required. So when we looked at how they fared at the end of 3 years, we found that there were 3/4 of patients were at their pre-specified target pressure without medication from the laser first group. So if they had SLT, some of those had a second SLT, round about a quarter, but of those patients who'd had SLT as their primary treatment, 3/4 were drop-free and at target pressure at the end of 3 years. So no need for medications, a comparable level of quality of life on the metrics that we've got, albeit relatively crude, and that came with very little risk, because the laser itself was incredibly safe. There were no immediate or late complications. There were no sight-threatening complications, and only one patient had a pressure spoke that required any form of treatment. They had 1 tablet of Diamox, and that was it. These are the number of medications required, and so 78% of eyes, or 3/4 of patients, were drop-free. So some of the questions that we got on to ask are, can we repeat the SLT? And we looked at those eyes that had failed, and we had 158 of those, but then went on to have a second laser. On average, the treatment power was slightly greater. And here we've got that group of patients, the same group of patients at 2 different time points. The initial SLT over time had failed in the first 18 months, but when they had a repeat SLT, that extra laser seemed to have got them their trabecular meshwork function back up, and they had a much more prolonged pressure control, achieving that target pressure. So not an arbitrary 20%, but a specific, eye-specific, predetermined target pressure based on severity. So repeat SLT, not only did it work in the early failures within the first 18 months, but it seemed to work better. So I think it was a very exciting outcome from the study. We also looked at the economic valuation, and laser first was in fact more cost effective. So laser first gave drop-free disease control, it was safe, no side effects, and I would propose should be considered for all newly diagnosed patients. We've got other findings that look at the specific proportion of pressure reduction, and we've also very recently published and compared the visual field outcomes from the two groups, suggesting that the laser first treatment paradigm, probably because of compliance issues with the medication group, actually gave better visual field preservation than did the use of medicine. So thanks to the local study group, sorry I don't have time to enumerate them all, but the new treatment paradigm in the post-light era, I think, will be starting off with SLT, perhaps going on to a preservative-free monotherapy initially, but then very rapidly moving on to minimally invasive glaucoma surgeries or possibly even injectable drugs, all of which are aimed at prolonged pressure control, but with minimal patient harm and minimum patient involvement. So thank you very much for that. I look forward to questions from that at the end. We should move on from that vision of the hopefully near future where we get away from multiple medication exposures and extensive preservative-free, and we're moving on to extensive preservative-free monotherapies. And now we'll hear from Francesco Odone, who is going to talk to us about optimizing the therapeutic management of our patients and what insights we can get from the real-world evidence that's out there. Thanks very much. Over to you, Francesco.
Thank you, Gus, for the nice introduction. And just start outlining what we will talking about in the next few slides. So we will overview the relevance of real-world evidence and the complementarity with randomized controlled trials. We will see why it's important to conduct and to get information from real-world evidence trials. Then we will overview the visionary study key results and lesson learned. And then we will try to view those results in the context of the situation related to the COVID virus we are facing during these times. We start gathering information regarding new drugs when during the drug development phase before the approval to input the drug itself in the market. And this is when drugs are tested in small and well-controlled patient populations, and this is done through interventional clinical trials, so the randomized controlled trials. Once get the approval, usually pragmatic clinical trials are conducted to compare the effectiveness of 2 or more interventions in real-world settings. And examples of pragmatic clinical trials are the LIGHT trial that we just heard about by Gus, and for example, the EAGLE trial. And in those trials, protocol dictates which approved drug the patients will receive. And after that, the drug is used in a large and less well-defined patient population over time. And so at this time, what takes place is what is called non-interventional studies, where patients are already taking the drug, and the protocol, the study protocol itself, dictates only what information to collect, but not what intervention the patient will be assigned to. So it's just an observation of what in real life is happening. So these kind of studies, of course, have a weaker internal validity compared to the well-designed and well-structured randomized controlled trials, but benefit from a larger generalizability, since sample being studied are representative of much broader target populations. In fact, limitations of randomized controlled trials regards the fact that data from RCTs are limited for demonstrating an intervention's long-term safety and effectiveness or its generalizability in different target population. And so there is an increasing need for additional insights on epidemiology, compliance, adherence, and costs in a realistic environment. And those kind of information cannot be obtained through RCTs, but only by using real-world data sources. And so real-world evidence, if we want to try to conceptualize this term, can be defined as data that are collected outside the constraints of conventional explanatory or pragmatic randomized controlled trials. And also, regulatory bodies are increasingly suggesting to conduct this kind of studies. This helps physicians with their glaucoma treatment decision in their routine clinical practice. And there are a number of sources of real-world evidence. Among those sources, there are observational cohort studies. And the visionary study I would like to talk about at this point is one of such observational prospective studies that was just published a few days ago in Advances in Therapy. And the study had as an objective to evaluate the efficacy, tolerability, and safety of the preservative-free tafluprost and timolol fixed-dose combination in a real-world clinical setting in adult people with open-angle glaucoma or ocular hypertension, demonstrating insufficient response to topical beta blockers or prostaglandin analog monotherapies. And the primary endpoint was the absolute mean intraocular pressure change from baseline to 6 months. There were a list of secondary endpoints. Among them, there was the mean change of intraocular pressure from baseline, a responder rate, and safety and tolerability endpoints. The visionary study was a European multicenter study that involved 66 ophthalmology clinics across different countries and screened 721 patients. Of those, 577 completed the 6 months visits. And this is a chart of the study design. So patients were visited at the baseline, where intraocular pressure and tolerability endpoints were measured, and then were followed up for 6 months with interim visits at 4 weeks and 12 weeks. And among the inclusion criteria, the only one I want to highlight is that patients to be included in this observational period had to have insufficient intraocular pressure control with previous monotherapy that had to be either with beta blockers or prostaglandin analogs. And patients also had to be judged by their physician to benefit from a preservative-free eye drop formulation. Here we see what proportion of patients was on PGA therapy. That was 72% compared to 28% of patients that are baseline were on beta blockers therapy. And this represents like a breakdown of the market of these two class of hypotensive agents. And here we have the first results regarding the efficacy endpoints. Mainly, we can see that intraocular pressure from a baseline of 21.5 dropped at month 6 by 25%. That was 5.7 millimeters of mercury. And this was regardless of previous treatment. This was maintained from week 4 to month 6. Then we have a breakdown according to the baseline therapy that could have been either beta blocker or PGA. And as we can see, a drop of intraocular pressure by 28% was observed in people previously on beta blockers compared to a 23.6% in people previously on PGA monotherapy. So this demonstrated that the fixed combination was effective regardless of the class of hypotensive agent used before. Again, we have a breakdown according to the type of prostaglandin analog used at baseline. And we can see here that a significant reduction of intraocular pressure was maintained over 6 months, regardless of the kind of prostaglandin analog that patients were on before starting the study. And the differences you can see between the different prostaglandin analogs here very likely are related to the differences in the baseline intraocular pressure, which was slightly higher in people that were previously in latanoprost compared, for example, to the other compounds such as travoprost. Actually, approximately 7% of people had intraocular pressure reduced at least 20% from baseline, and approximately 40% had a reduction in intraocular pressure of at least 30% from baseline. Regarding safety and tolerability, corneal fluorescein score significantly improved throughout the follow-up until the 6 months, and has improved also the tear breakup time, especially in those patients that were previously treated with the prostaglandin analogs. In this quite crowded slide, actually what we want to focus on our attention is the red arrow pointing down that is showing the reduction of patients that experience severe hyperemia, which was completely resolved for those patients that were previously on latanoprost, bimatoprost, and travoprost monotherapies, and that reduced by 14% in those patients that were previously on tafluprost monotherapy. Again, during the study, patients were also asked about a range of subjective symptoms that were reported to be significantly improved by 25 to 30%, and this regarded dry eye sensation, irritation, itching, and forehead body sensation. During the study, also patients and physicians were asked about their tolerability, their judgment, their subjective judgment about tolerability and the efficacy about the drugs. And we can see in this graph that almost more than 90% of patients and physicians at the 6 months judged the treatment to be more effective and more tolerated than what was previously ongoing. Concerning the adverse events, we can see that more than 80% of patients experience no adverse events, and those patients that experience adverse events experience mild, principally mild. 93% of patients experience mild adverse events, and most of them, 71.3%, resolved or were resolving at the end of the study. So what we can, try to summarize about what we have seen regarding the visionary study. That the visionary study reflects real-life clinical practice and a potential for clinically meaningful intraocular pressure reduction shortly after changing to preservative-free tafluprost and timolol fixed combination from either a PGA analog or a beta blocker drug. And that patients on all currently available PGA monotherapies may benefit from changing to this fixed combination therapy. Even patients considered intraocular pressure control gained an almost 20% further intraocular pressure reduction after the shift. And of course, as any real-world study, it has some study limitations. Of course, the observational nature of this data collection has intrinsic noise that, of course, can limit the power of detecting some changes throughout the follow-up. The ethnicity was mainly Caucasic, so the results cannot necessarily be extended to other ethnicities. And of course, the kind of disease that was treated was open-angle glaucoma and ocular hypertension, and we cannot necessarily extend the results also to other forms of glaucoma. So lastly, what can we learn from this study, which might be increasingly relevant during this current period of lockdown and restriction due to the coronavirus? So we can say that having a tolerable and effective treatment can reduce the likelihood of extra consultations related to either efficacy or tolerability issues. And this will be a benefit, of course, for all patients, but especially for the higher risk populations, such as the aged, elderly glaucoma population. So I would like to thank all the people that were involved in the visionary study. Here you see a list of principal investigators, but there are as many co-investigators and staff that were involved in this study. So thank to all of them, and thank you for listening.
Thanks very much indeed, Francesco. A very reassuring, but also very tantalizing view of what can be achieved with some very, very powerful, simple, single treatment, preservative-free preparations that are available to us now. So thank you. There are a few questions that have come in, which have come in from a number of different individuals. So it would be nice to touch on briefly. A couple of very clinically orientated ones. One of the first of which was that given the risk from aerosol generating procedures, does that mean that we should be using non-contact tonometers? David, do you have a view on this at all?
I think there's some really interesting research out there looking at alternative ways of measuring IOP. I think it's worth kind of looking at that, and obviously non-contact seems to be, in the current climate, would seem to have some advantages. But I think I would leave that opinion to my clinical colleague, maybe Faisal, perhaps.
Yeah, I think there was a paper out from Hong Kong very recently from an department saying that actually things like air puff tonometry and the corneal hysteresis were aerosol generating devices, and therefore actually we were looking at it in regards to how we could do the monitoring service and quicker ways and safer ways to do it. But actually I think it's counter to safety in that actually it is an aerosol generating procedure, and therefore things like Goldman and eye care and things are actually better.
Francesca, what are they doing in Italy?
Actually, yes, I agree to what has been just said, that the eye puff tonometry probably is not the technology of choice for the aerosol generation potential. And we are mainly using the Goldman applanation tonometry with very strict rules about disinfection of the cones, or using single-use disposable cones, which are not very loved by the ophthalmologists because the view is not so clear, and so tonometry can be very, very difficult, very tough. Actually, I think that the rebound tonometry, the eye care, really has the potential to solve a lot of these issues. There are clinics in Europe that are were run in the past since years, just with the rebound tonometry. I'm thinking about the Ania Tulonen clinic in Tampere, for example. They use just eye care since a long time. And I think that it is a reliable technique, and it uses disposable tips. So I think it can be really a good choice.
I would only put the caveat in of using eye care when, for instance, you're using it as opposed to the slit lamp microscope, where we wear a mask, we have a shield guard, the patient's wearing a mask and so on. When you have the eye care, you're just lacking that shield that we have on the slit lamp as well. So it's a bit more direct. That's the only caveat I'd add with the eye care.
I think what's interesting from the discussions, we've had a number of different discussion groups going on, from sort of Glaucoma Service leads from Singapore, UK, and 3 or 4 sites in the States, Johns Hopkins, Baltimore, and others. It has been the real spread of opinion across the world. A number of people have set up eye care only stations. Some people have steered clear of GAT because they are worried about the closeness of patient contact and breath exchange. And then others are continuing with aura-based devices and non-contact-based devices such as the aura, because of the concerns around aerosol generation are present, but the evidence for presence of active viral particles other than just RNA antigen, but actually infective viral particles in the conjunctival surface, on the conjunctival surface and in the tear strip, is very weak. I think, unfortunately, the honest answer is that none of us know. We're all making our own decisions based on what I was touching on, which was independent, personal, or departmental views of risk assessment. An interesting question from Peter Gray here. This is directed to you, Faisal, but probably applies to all of us clinicians, which is that you mentioned that the social distancing will reduce the number of clinic patients in clinic. Where is everyone else going to go?
Well, firstly, we're going to have to remodel the service anyway, because as we get more and more data, of course, college guidelines say that if a large significant patient population that we have in glaucoma, ocular hypertensive are suspects, and the fact that we can get this data properly means that there'll be hopefully a significant, I don't know how large, we tend to be quite strict, but a significant number of patients who we think, well, we followed you up for 5 years, we can kick you out of clinic for a start. So you're making a bit of space for patients, and they can be moved out into the community. But also it's a great way of introducing models where we have community care for looking over the lower risk patients. We may even be looking at, for cataract, all our services. We can't just stay glaucoma centric. And it may be that looking at functional loss will persuade the departments that actually we need to concentrate on those patients who are losing vision for reasons that we can treat properly, rather than patients who have other conditions. And there may be a remodeling of our services whereby glaucoma, medical retina, and so on have a large proportion of floor space. We certainly will have to go into the evenings looking at having more consultants so that we can have more sessions, because we can have less patients per clinic, but also the telephone calls and so on. And if David Crabb's, fields from home work, then that will again increase the floor space in the hospital. So we're having to bring in patients less often. You can get eye care that you can do on your own at home. So you can buy an eye care tonometer at home from the company and do your own eye care. It does have a Bluetooth connection. So theoretically, you could do your eye care and your visual fields at home, where you don't even need to come in then, Gus. You can just do all your stuff at home. The computer will say, yes, the patient is stable and reliable, and you don't need to see them again, or no, they're not reliable, or they're not stable, and they need to be seen by you.
I think this is probably the most exciting time in ophthalmology, certainly for glaucoma, but some might differ. But some of the most exciting time in ophthalmology that we will see in our lifetimes, and certainly for generations. I think we've got the opportunity to throw away the rule book, rip up what we've done before, refashion the whole of our services, probably better than it's ever been done. It's going to be a bloody hard work, but I think it's going to be, a really, really exciting prospect. We've certainly looking forward to transferring the bulk of our care to remote data collection. So asynchronous decision making, I think, is in the jargon, where patients are seen at another time, at another place, and that data is then reviewed remotely. And you let them have the information and the answer personally over the phone, or possibly on a video conference call. So really exciting times. David's going to lead the charge, obviously, in armchair-based testing. But I think putting all of this together, it's going to be a different world in 5 years, but probably in 2.
Yeah, I completely agree. And I think there are already virtual models running where for many years, there are services with especially in glaucoma, the monitoring services that are run by optoms or techs, whereby the patients are seen one day and they're reviewed by the consultant the following day. And we've been doing that at the Western for well over 5-6 years, and other units around the country in the UK have been doing it well over 10 years. So there'll be more and more of that happening.
Yeah, of course. I mean, we've got a Caden Street Optom-led virtual data collection model that's been running very well, seeing an increasing proportion of the clinic over the last few years, and I'm hoping that we'll be able to push that well beyond half of the current 69,000 patients for which we're responsible. couple of a few questions coming in. The last few minutes, I realise that we're over time, so apologies to those of you who are still on the webinar but anxious to get on with supper or getting the kids to bed. I've missed one and I'm avoiding the other. But there are a couple of questions about SLT. Somebody asking, Jigs Patel asking if SLT should be first-line therapy instead of medical therapy. I would say yes, wouldn't I? Because the trial showed that it was effective and worked very well. What's going to be interesting is not what I say, but what NICE and the American practice patterns say. So the American Academy of Ophthalmology, PPP, guidelines are not yet published, but the word on the street that I couldn't possibly mention to, but between you and me and 1,000 people on the webinar, there's a suggestion that they may be recommending it as first-line use. The NICE guidance have announced publicly that they will be rewriting NICE guidance for glaucoma based on the publication of the light trial data. And so the presumption is that they will suggest that it should be offered to people as first line. And that is now our de facto standard, certainly at Moorfields, for all of our new patients, or indeed patients on monotherapy who are now offered it. Some of the other questions, a question for Francesco, which was really, how do you think that sort of real world data will fit in with the regulators? Do you think the regulators are lagging behind the ability of big data, real world data, to change our practice?
I mean, actually, regulators are asking for real world data. I mean, they are a complement. Of course, they are complementary to data coming from a proper randomized controlled trial. And I think that real world data have the power to change the way regulators behave regarding the drug policy. So if this was the question, I think that yes, they have the power to change things. Of course, Gus, what I can add is just that real world data are important, but as I showed in the graph at the beginning of my talk, they are just information that come and have sense after what has already been gathered through randomized controlled trials and pragmatic trials. So data from real world evidence just alone, they have no sense, no power to tell anything, of course.
Right, thank you. So I think on that summary of sensible pragmatism, we should let everyone get on with their evenings. Apologies that we've run a little bit over time. Thank you to the organisers for letting us do that, because I think it gave us the opportunity to really answer some of the more frequent questions that were coming in, certainly some of the more clinically pertinent ones. So thank you very much, Faisal, David, Francesco. It's been a pleasure. I look forward, I hope, to seeing you in person one day, not too distant future. And thank you very much to our audience for listening.
Thank you very much.
Thank you. Thank you. Thank you.
Thank you very much.